Good afternoon. Thanks for everyone for coming to have lunch with us. I wanted to introduce our first speaker, who is Sarah Brayshaw. She's a nurse coordinator at National Jewish Health in Denver, Colorado, who works with the adults. She's been a nurse coordinator there since 1999.
Hi, everybody. It's so weird to be back up and seeing people. I was so nervous about this, and then I realized that we're all friends. So we're going to be fine. So I have no relationships to disclose. Today I'm going to talk about managing team turnover, challenges, changes, and trying to bring joy back into clinics. So we talked about this talk with my coworker Kathy and I, and a lot of different titles could have been this talk, right? Like Trikafta, yay, COVID, what just happened, clinic growing pains, and now what? How do we go forward? So I wanted to spend a minute talking about our center and the growing pains that we have experienced. So I started this career in 1999. I was 10, because I cannot possibly be this old. And it started as a very, very small CF center, growing into a medium-sized center, and now we are the largest center in the United States. The staff was 2 physicians, part-time research, part-time clinical nurse when I started. We had some like hospital social work help and dietary help and RT help that just kind of came to one clinic a week to see what they could do, but we didn't have anyone really designated. Today we have a staff of 35 people in our clinic, 7 pulmonologists, 7. That's a few too many. 1 endocrinologist, 1 gastroenterologist, a clinical psychologist, and 2 nurse practitioners. So I've seen this patient population grow from around 100 when I started to our most recent count by the CF registry of 603 patients that we take care of. We also have moved our inpatient hospital 3 times since I have been here. This is a pretty big feat. I don't know if anybody has ever tried to move an entire hospital. And the last time we moved from an entire hospital system to a new hospital system with all new staff, all new floor, all new training, all new equipment. So I think we had weekly meetings about how to run a CF clinic for about a year. And this is just another graph of how our center has changed. I think the dip in 2014 is when we had to reconsent everybody for the registry, and we didn't do a very great job of that for a while. But as you can see, both our staff and our clinic population has grown quite a bit. So we had this cute little staff back in 2002. 3 of us are still in this room right now. And Dr. Nick and Dr. Saavedra and a couple retired research nurses. And this is our staff now. And I just would like to point out that there is a lot of estrogen in this picture. I also want to point out that Dr. Nick's picture has not changed since 1999, and we refuse to change it ever. This is a lot of personalities. So, in 2002, Kathy and I knew each other pretty well, still do. We knew the doctors pretty well. We worked pretty well together. This is a lot of personalities in the clinic, and thinking about how to make all of these people feel important and their job is worthy and that they're contributing, and how to get along with each other. These are all kind of new challenges in this very, very big clinic that we have. I'm going to now skip to the pandemic. That was pretty weird, right? One day you're in clinic, you're going along, the next day everybody is quarantined, and you have to figure out how to counsel the patients, how to counsel your staff. You have family members at home not knowing if they should let you back into your house because you are into a hospital every day. We were healthcare heroes for a while. Do you remember that? That has changed. But that was fun, the howling, the banging at 7 o'clock at night. Then the vaccines came out, and we all had this hope of living again. But then there was the politics involved in the vaccines. And that really divided a lot of healthcare systems, a lot of employees, and a lot of patients. We had patients who wanted us to write letters saying that we agreed with them that they should not get a vaccine. And in our clinic, we chose not to write those letters. And so we really had a lot of angry patients too. And telehealth. We had no telehealth before the pandemic. Did anyone have telehealth before the pandemic in this room? No. So that was a very fast new thing we had to figure out how to do and how to schedule and how to get that information to the patients and how to do home spirometry and how to get the sputum cultures and labs for their new medication. So this was a challenge, and how to incorporate all the multidisciplinary team members into these telehealth appointments and to utilize the staff that we had. So back to the beginning of the pandemic. This is some of the stuff we felt when we were all working, right? This was the hallway going up to our hospital inpatient floor. They had all of these great chalk drawings about how proud they were and strong, and we're gonna get through this together. Got lots of little gifts, got lots of food, as evidenced by more food in this picture. Letters and encouragement and all of this kind of pride of being a healthcare hero. We also had a bubble, right? These were our bubble. We had ourselves in our office, and we lived and worked and breathed together. I think I had the first Easter, I had most of my clinic staff come over because nobody else wanted them in their family because we were all dirty and infected hospital workers. But we had, people bringing us masks. The middle picture here is us sending a message to our patients on Facebook that we're all still here and we're all working. This picture of our social worker with her nails, she would kill me because one, she doesn't like pictures, two, she doesn't ever do her nails. But we made everybody do manicures together. We exercised in our office. We ate in our office. We celebrated birthdays in our office. We did yoga, we did meditation. I think we have moved from that office, and probably the floor has a lot of stories of sweat and maybe some pretzels and chips that fell on the floor. Our team also did a half marathon where we either ran, biked, or supported each other with margaritas after the marathon and raised money for our local chapter. So we really tried to get through this beginning of the pandemic together. Okay. And then we got this right before the pandemic, Trikafta came, right? So everybody was so excited. Life was changing. Patients were excited. We put them right back into the closet with the pandemic. But the CF culture has changed, and I think that a lot of this conference has been about that change and how we're thinking about taking care of these patients. So inpatient services are down, which we spent a lot of money and time building that new hospital because we had at least 12 patients always admitted at our hospital, the highest being 31 at one point. And so we built this very beautiful new hospital, and now we don't have patients to fill them, which is great for the CF community, but not great for hospital administration. And CF is becoming more of a chronic disease management, less about our acute care needs, where we used to be always triaging and trying to kind of figure out how to best take care of kind of emergent situations. And we've seen this, or a version of this slide, a million times, right? So much progress through treatment. This slide gets me emotional, especially being here this year at this conference. I started in '99, the life expectancy was 31. And so thinking about being here at this conference, hearing the new life expectancy and being able to get rid of some potentially treatments burden, this is pretty amazing, right? And one of the centers my director visited recently, he was saying that every single person at that center, not one person knew what it was like to take care of a CF patient prior to Trikafta. The whole center was that new. And I think that's amazing and also so weird to not know what it was like to sit with some of these people day after day, being very, very sick in the hospital or at home or in clinic. We're really lucky we had 95% of our patients eligible for modulators. This shows that our pulmonary exacerbations have went way, way down. So we did a survey to the nurses in the listserv, and we asked how highly effective modulator therapy has affected our CF practice. And obviously it's been a decrease in the referral to the lung transplant program, and that was talked a little bit about in that plenary session. Fewer episodes of home antibiotics, fewer hospitalizations, increased missed appointments. We have patients that our doctors schedule that will have 8 to 10 patients on them, and we'll always have a couple that don't show up, it seems. And then this increase in these telehealth visits. And I think this is gonna stay. Telehealth is gonna stay, but we do need to have in-person visits. It's very hard to listen to someone's lungs through a computer. It's very hard for the multidisciplinary team to do what they need to do through a telehealth appointment. And how has this affected the CF practice? Obviously, there's decreased use and adherence to inhaled antibiotics, pulmozyme hypertonic. Other than modulator patient visits, which are required to get their modulators, they don't want to come as much anymore. And our CF cultures are not done every visit. And then this question was, is there been turnover in your CF staff? And it was really interesting in the program coordinator meeting yesterday, talking to a lot of the coordinators about just how much open positions and staff they have open right now, and how kind of upper management is not super supportive of filling some of those positions. COVID-19 did get rid of a lot of healthcare positions. I think National Jewish got, fired 40 people after the vaccines and after the initial kind of COVID outburst. There was a lot of burnout. People just don't even want to be in healthcare. We have a old pulmonologist that's being a farmer now. There's more attractive job offers elsewhere, right? So you're a young person and you don't have family and you can go travel to another place for a month and get $10,000. Why wouldn't you do that experience? So lots of different benefits and bonuses and whatever, so it was very hard to keep a staff together. And the last question we asked was, what ideas, processes, if any, have been implemented at your center to help with staff retention? And some people said there were some mental health programs, and people were able to work from home more than they were in pre-pandemic days. And then some people said none, which I think is probably more the case in most places. So what's a new normal? We have a very active QI team in our center, and we hadn't got together for a couple years, right, Katie? And we decided that would be fun to get together and do it again, and we literally got together and looked at each other and said, what do we do? What is our new project? And we did transplant, nutrition, diabetes, med lists. We went through all of our old transition programs, and all of us were like, moods were just not there. And we started talking about how COVID has made our team feel a little bit more fragmented. We didn't do as many activities outside of work. We didn't go to NACFC in person and maybe go to some parties at night. We felt less connected to each other. And so we remembered a poster from the 2019 conference in Portland, I think, that I've asked my friend and coworker Christine 16 times where it came from. And it was a happiness project. And we really were talking about that. And the whole QI team's face lit up. Let's talk about bringing joy to our staff. Because if our staff has joy, then maybe we can bring that to our patients better. Maybe work environment will be better. And this is the reason that I keep asking Christine why, where it come from, because the picture's really terrible and I'm sorry, but I just wanted to give it props because we really, really, really loved this whole project and about creating joy within the workplace. So we started looking at different ways that we could look at job satisfaction. The atmosphere in the team and in the office is so important. So, if you go in to the clinic and someone's very off or in a bad mood, right, it affects everybody. So trying to create an atmosphere that is a little bit more positive and upbeat helps the whole clinic day. Work-life balance is so important. As the manager of this clinic, I never want anyone to be scared to say that their kid has a volleyball game, that their child has a doctor's appointment, that they need a mental health day. You're not going to be penalized by trying to balance your home life with work. You should work to live, not live to work. I have no control over salary. I really don't have a lot of control over working conditions, but we can try. Varying your work, not just coming in doing the same thing over and over, giving some different development opportunities, and being a little flexible and giving your staff autonomy, making your job your own, supporting ideas that your staff may have and come to you and saying, go for it, try it. This is your position. Let's see if it works. So when I put this slide in of Mr. Rogers, my friend from my childhood, I realize that I'm older than a lot of people now, and I used to be younger. But Fred Rogers, for those of you who are younger than me, was a public television hero for children, and he had a show called Mr. Rogers' Neighborhood. And if you are too young to know this, look him up, because he has a lot of really good things to say. But Mr. Rogers said, as human beings, our job in life is to help people realize how rare and valuable each one of us really is, that each one of us has something that no one else has or will ever have. Something inside that is unique to all time. It is our job to encourage each other to discover that uniqueness and to provide ways of developing its expression. Pretty crazy good, huh? I think all politics should probably read Mr. Rogers' words. So how did we start implementing this? We want to celebrate each other. We want to get to know each other. The clinical staff started birthday buddies where we draw names. And so one person has your name and they bring some kind of snack to clinic, like a birthday cake, and a certain amount of money is allocated to each person for a present. We started doing newsletters to patients featuring one team member, each newsletter. We had weekly Zoom meetings, and each part of our clinic, research, lab, clinic, hospital, all kind of talked about what was going on in their worlds that week to get to know each other. And then we decided we needed some outside activities to re-get to know each other, because when you start understanding who people are outside of work, it's harder to be kind of crabbier inside of work. So we developed the Sunshine Activity Club. Now, if you want to know what we call it secretly, ask me later, because it's inappropriate for this audience. But we decided that we were going to have once a month activities that everyone in the team could go to outside of work. And so this included different CF events, different runs. We had a Christmas in July party. We've had some Sunday hiking adventures. We had a chef challenge adventures. And not obviously everybody can come, but it is a way to get to know each other personally outside of your environment at work. So in conclusion, we've been through a lot. It's been crazy, right? There's so much changing in the CF culture with Trikafta, pandemic, vaccines. Our clinic growth and changes has been unimaginable to me. And making the work environment as fun and a collaborative place as possible is the key. Outside work, getting to know each other outside of where we are working every day, and really to make people feel needed and important is the key, like Mr. Rogers said. And last thing I want to do is, this is a design that one of our patients made. We had a contest where we asked all the patients to do artwork for our clinic, so we made everybody in our clinic shirts. And this came from one of our patients who I think is 60-something now, right? And that was really a fun thing for us to do, to incorporate patients with our team and then to give everybody these surprise shirts. So I want to thank you all for listening to me babble this lunch period. And I was honored to be here. So thank you very much.
Anyone have any questions or comments? I don't see any written.
Oh, yeah.
Well,
I actually have a question. In terms of so 2 questions. When was the last time you had a new staff member? And then how did you onboard them to make them feel welcomed in this already established team that,
yes,
Yeah.
please.
We've had 2 new ones. One started last week-ish. And then we had a respiratory therapist that restarted a month ago, maybe. And the respiratory therapist had been with us a few years ago, moved away, and then came back to us. So that was a little bit easier because she already knew most of our staff. The new one was a research nurse that is now becoming a research coordinator. It is a program coordinator, please. And I think that we were lucky enough that our old program coordinator got to spend a little bit of time with her. And we were also lucky enough that she was an inpatient nurse too, and then became a research nurse and now is a program coordinator. But it's hard. I mean, especially when a lot of us, 4 of us in this room have been together for at least 15 years, some of us longer. And to be a new person walking into this very established group, I think we've tried to realize that it's hard for these patients.
I think it can be really
people.
intimidating for
Very
people
intimidating.
because a lot of us have been there for a while, but
Yeah.
also I think that people like to see that we have a really good camaraderie because a lot of us have been there for a while,
Right.
and we try to make them as welcome as possible.
Yeah.
And we have a very tight space, as most of you guys probably do. Like, we have 6 people in an office about as big as this stage, and so when they are with us, they get to know people very quickly.
Yeah. And I do think some of these outside activities, including people and getting to know them outside of just coming into this intimidating space and learning about their spouse or their partner and their kids. And I think when you know somebody a little bit outside of that workspace, it's easier to be more comfortable. But
Sure.
it's hard. I wouldn't want to walk into our group. I think it's intimidating, for sure. Or we just hire daughters of former employees or siblings of employees. We're very nepotistic. Yeah. Oh, good. Thanks, Val.
any other questions? All right. Thank you, Sarah.
Oh, thank you.
All right, next up we have Molly Riley. She is with the Akron Children's Hospital, and she is also going to split it with a colleague, but we'll first welcome Molly to the stage. And since Jennifer came to the stage, we'll also welcome Jennifer as well. So take it away, ladies. Thank you.
And we're actually going to talk to you from the vantage point of new employees. We've only been with our group for 1 year. And we have no relationships to disclose today related to this presentation. So our goals today are to review the pandemic and modulator impact on the allocation of staff and best practices for onboarding and staff retention.
Our objective is that Jen and I hope you leave here understanding that there are several ways to respond to team changes, and that we hope sharing our experience of orienting with new staff will help prepare you for future onboarding of new members.
So I am Jennifer Moore. I'm a registered nurse. I've been in healthcare for 20 years, 17 of those in nursing. So I have 11 years in pediatric care, and I have 7 years working with adults. And I was hired as the program coordinator for our center in November of 2021, so I'm just coming up next week on my 1-year mark with them. But I am the full-time program coordinator for both programs. So I get to work with everybody from newborn to our oldest patient, who is 70 years old.
A brief background about me: I'm Molly Riley. I started my nursing career at Akron Children's in 2017 on an adolescent medical surgical unit, and that is actually where I gained my experience and interest in CF, because I provided direct care to both the adult and pediatric inpatient patients. And then in October 2021, so I just hit my 1 year, I transitioned from the inpatient unit to the outpatient clinic. And I am primarily the pediatric RN for the ages newborn to 21 years old, and some of which I actually knew these patients who were admitted inpatiently, and mostly during prior to modular therapy. So a little background about my experience on the floors. Working 4 years on the floors, I was able to actually witness the incredible positive impact of modulator therapy. Prior to modulators, as we all know, it was common for several patients to be admitted all at the same time, requiring a higher need for nurses, and also just because they were considered very complex patients of higher acuity. With the rise of modulator therapy, there was a decrease in CF admissions, and they were presenting, when they were presented to the hospital, they were of lower acuity, which resulted to lesser need for nursing. So as there were hopes for the future of cystic fibrosis with the start of TRIKAFTA, our world was faced with the fear from the pandemic. A nursing shortage arose as many hospitals were undergoing hiring freezes to save funds, ultimately leading to staff burnout. As the pandemic had negative effects on staffing, TRIKAFTA actually had the positive effect on both the inpatient and outpatient setting. There were fewer admissions, and CF patients were presenting less sick on admission. In the outpatient setting, nurses received less sick calls and visits, and were performing less central line care as there were less patients on IV antibiotics. Although clinic was not as busy, nurses were delegated and preoccupied by taking on roles that were lacking due to staffing shortage.
So we all know how challenging things have been the past couple of years. And because of the COVID restrictions and that low staffing that we've talked about, there were many things that we had to place on the back burner. So some of those things were monitoring of labs, completing testing like DEXA scans, chest x-rays, getting those OGTTs done. Staff, as she said, were pulled to cover other areas. And multiple nurses in our center were covering pieces and parts of the coordinator role. Group meetings ceased, education night ceased, and quality meetings had to stop.
So the CF team recognized the need for staffing during the pandemic, and with the complexity of CF consisting of a multidisciplinary team, several interviews were organized for the potential candidates. The hiring process first began with virtual interviews with our HR and then our hiring manager. Then in-person interviews were arranged, with the CF director, Dr. Omler, and our associate director, Dr. Strawbridge, along with the nurse that was the CF nurse at that time. The team gave the potential candidate also the opportunity to shadow a CF clinic day. As I was a potential candidate at that time, this allowed me to observe clinic flow, meet some of the patients, and introduce myself to the entire CF team, as they were both follow-up appointments and annual appointments. This gave the potential candidate who may not have had any CF experience the opportunity to better understand cystic fibrosis. It also allowed us to feel a part of the CF team before potential hiring, providing a very welcoming and positive environment from our potential coworkers.
So starting in the fall of 2021, we began this hiring process to fill many positions. Nurses came on board in September and October. My position began in November. We had a research nurse on board with us. A respiratory therapist came along at the end of the year. A new social worker joined us in January. And since then, we've gained a new genetics counselor. We've had a new dietitian join our team as one retired this summer. And we also brought on a new pharmacist. We are fortunate to have a complete team now after a few years of being understaffed. And with a full team, I feel confident we are providing the best care possible to our center. And we have 155 pediatric patients and about 75 adult patients. And because we've hired so many new team members with various levels of CF knowledge, it was imperative to onboard everybody very thoroughly.
So then I was hired after several interviews and participating in the shadow experience. I was hired as a part-time nurse as a shared position with another newly hired part-time nurse. The CF clinic was going through several changes, staffing changes, as Jen explained, in which affected our orientation as a whole. There were a lack of preceptors and resources to educate us on cystic fibrosis. Standard work instructions were provided for us, but because of the pandemic and lack of staff, roles and tasks were not clearly identified. Our director and associate director recognized the need for a better orientation. With Jen starting her role as the CF coordinator a few weeks after us, they decided to set up weekly meetings and educational sessions to better our orientation.
For my position, things that really worked well, we did get to shadow each of the disciplines. I was able to come in and focus on the adult team for about 6 weeks before I switched my focus to work with the pediatric team. We had these provider education sessions, which we're going to talk about more in a minute. I had weekly check-ins with leadership. And I was provided with an orientation binder that had some education and some standard workflow instructions. Some things that didn't work as well, determining how to orient my position between two teams. As previously, like I said, with the coordinator job was kind of pieced together by multiple people. And then prior to that, there were separate pediatric coordinators and adult coordinators. So there was no real specific onboarding process for me as a coordinator. The roles and responsibilities of our staff were kind of blurred. As we said, everybody was being pulled to cross-train in other areas or cross-cover. People were taking on roles that they wouldn't normally take on. So trying to find that balance, whose role is where and what they should be doing. And then the teams all had different views of what my role entailed and where I belonged within the group. And some of the things that were really good for my orientation and my involvement with the team, I had these frequent meetings with the directors and the managers initially, these monthly team meetings, specific leadership meetings. I was encouraged to get involved with the foundation right away and get involved with our local chapters. I joined the coordinator listserv and started attending the forum meetings every month. I also joined a committee, the Toolkit Committee, that was announced yesterday for the new resource for new coordinators. This is where I learned a lot of information that was very important to my role. I also applied for the mentor program, and I've been able to reach out to other coordinators in our region to introduce myself and start creating those resource relationships with them. I do stay involved with the hospital councils as well. So in the department, we have unit-based governance council. We have flu initiative meetings. I do get involved in those. And then on the hospital level, our center is located in a hospital. I do participate on 2 councils, so our ambulatory shared governance council. And that is for all of our ambulatory areas to have a voice where normally inpatient kind of takes over. I get to keep our department and our CF center kind of relevant with everybody. And I'm on the Professional Development Council, and that keeps, again, us relevant with the inpatient side of things.
So as mentioned, with a new CF team, there was a need for education. And some of these nurses that got hired, well, my other coworker, Christina, who's the other part-time nurse with me, she had no prior CF experience, and I just had inpatient experience. So there was a need for education, and so we organized these weekly education sessions. With the help of the providers and other experienced CF team members, we formed these weekly sessions to help us learn more about cystic fibrosis since it is such a complex disease. We first met with our director, Dr. Omler, who discussed the process of performing a PFT and how to interpret the results. We were also given the opportunity to meet with our research nurse, Michelle Powers, and our respiratory therapist to perform a PFT, so that way we were able to kind of get on the same level as our patients and understand that is a very hard test, even if you don't have CF. We also met with our respiratory therapist who went over airway clearance, and we were able to have the hands-on experience of trying on a vest and experiencing they went over all the different vests in the settings. Then we met with our registered dietitian who went over supplements, went over enzymes and multivitamins, and she actually gave us a lineup of all the different supplements, and we had to taste all of them, which this was like my second week, and I'm like, oh no. But it helped me because a lot of people inquire about supplements, and you can kind of, you're getting on the level of them, and you can explain to them and educate them better when you're having this hands-on experience. She also gave us samples of a multivitamin. That's the multivitamin gummy, and it's a new gummy that's out, and half of our patients have transitioned to the gummy since it was so hard to swallow the pill for them. Then we met with our infectious disease pharmacist. She presented a presentation on bugs and drugs in which she discussed the common respiratory culture results, or the ones to be concerned for that need to be treated. And then she also discussed the different drugs that are used, along with the antibiotics, both inpatiently and outpatiently, that are the most common antibiotics to order. We then met with one of our pulmonologists, Dr. Aboud, to discuss the newborn screen process, and he also went over the process of a new diagnosis, and in which we were very worried to have a new diagnosis, and our first diagnosis was, I'll never forget this patient now, and now we have such a good rapport between each other because you want to present yourself in a very empathetic way, and you want to be there for them and show the support instead of overwhelming them and just causing anxiety for them. So he gave us some tips as to how to go about the first encounter and the first appointment with a newborn. We also created, in regards to the newborn screens, we created standard work instructions with our lab techs and our genetic counselor because we knew that there was not a very good flow between it and there wasn't a very good communication. So these standard work instructions allow us to figure out a way to have the process be more organized, and that way we can improve the process and get things moving. We then met with our social worker and also our nurse practitioner, Elizabeth Bryson, to discuss CF Rise. With CF Rise, I'm sure a lot of you guys are aware, but it's a program for our adolescent patients to gain knowledge and independence to manage their cystic fibrosis. We involve CF Rise every 2 weeks in our adolescent clinics. There are afternoon clinics in which two of our providers, Dr. Martinez and Dr. Strawbridge, and also Elizabeth Bryson, take time to get involved with CF Rise and have the parents step out of the room so that way we can gain this independence for these patients as they transition to adulthood. We also met with Elizabeth Bryson to discuss infection control and to just discuss proper PPE. And then she also really got us involved with PEP, in which we highly recommend getting involved in. PEP is a training program. It's a patient engagement program, and it helps you focus on patient-centered care and aim to improving the ability to engage with patients as active partners. And so each of the new hires, even our social worker, our pharmacist, and then all the nurses that were hired, we're involved with PEP now. And so we also try to kind of test our PEP skills in clinic. And so with Elizabeth Bryson's patients, we make sure that we are using those PEP skills to make sure that we're engaging the patients as active partners.
So once we were all oriented, everyone recognized a need to sit down and refocus our attention on all those items that we had put on the back burner. Nursing took charge of tracking labs and testing, and our completion rates for those labs and tests went up significantly this year. We restarted the Quality Improvement Committee with 9 members from all our different disciplines. And this year we worked on clinic flow, and we are currently still working on our OGTT completion process. The quality meetings actually became a really good bonding experience for all of us. We have specific assigned roles during these meetings, and every 2 meetings we rotate those roles. So everybody's had a chance to take turns being the leader, the facilitator, recording these meetings, and it's really given us a chance to get to know everybody's personalities a little bit more. I've also, in my role, been working on standard work instructions for all of our positions, and I think this is helping to unblur the lines that were the result of that cross coverage during the low staffing periods. My hope is this is going to make our team operate a lot more cohesively.
And so in conclusion, we just wanted to provide some of our suggested best practices for staff retention. We highly recommend creating those standard work instructions just to clarify any roles and what is expected of each team member. We also encourage you to provide these learning opportunities for any new team members, like weekly education sessions, and make them weekly so that way you're not overwhelming them with information, and that way they can retain just one topic at a time. Also, we encourage meeting with drug reps and participating in conferences like the CF conference to help us stay up to date with best practices. We encourage organizing frequent meetings with all the team members to discuss any questions, concerns, and to also share new ideas. This allows one to work as a team and to avoid a burnout. We encourage team bonding. We participated in the CF walk together. Again, we've only been together for a year, so we look forward to setting up dinners together and participating in any more like CF walks or marathons. I know a lot of us are runners, so we're looking forward to that. We encourage one to have an inclusive team approach in which creates an optimistic work environment. This helps one feel supported and respected by each team member. And lastly, we highly recommend new staff to be involved in the quality improvement projects. It allows them to feel like they are part of the team making a difference. And with new team members comes new ideas to help provide the best care for our patients, which is everybody's ultimate number one goal. So Jen and I just want to say we feel so lucky to now be a part of this CF team, and we feel so honored to actually be able to present at our first conference. And at this time, we would be happy to answer any questions.
You guys were awesome first-timers.
Thank you.
Comments or questions?
So y'all didn't have any SOPs before, standard work instructions?
Some.
Some, but not.
Yeah, there were some. There's still a lot that need to be put in place.
And who's assigned to make those? Like,
I'm just kind of taking charge of it as the coordinator.
Typical.
I have delegated a few of those out, but yeah, there's been so many changes in the last couple of years that even standard work instructions that were in place previously just don't really apply anymore.
Yeah, we kind of blame COVID for that, just because, I mean, there's sometimes nurses were doing roles of a secretary or vice versa. The secretary was doing a role of a nurse, and it was very inappropriate. But we were also desperate for the help. And so the standard work instructions just needed to be cleaned up a little bit to make it more clear.
can you hear me?
Yeah.
Okay. So for the orientation binder or packet, who assembled that? Do y'all have a computer specifically for your clinic?
No, so we have various team members that contributed to that binder. Again, with the older standard work instructions, there was information in there about CF therapies, the order to give aerosolized medications. There was information in the binder about some of our processes, our day-to-day things, contact lists, things like that. And my goal is, as the coordinator now, that binder just gets bigger and bigger, and those standard work instructions are placed in it so that if something happened and I were to leave the position and someone else walked in as coordinator, they could grab that binder and go.
And it was the help of our research nurse as well. So she's been in the CF clinic for a while, and so she was kind of our mentor towards this whole thing. And then the prior CF nurse became the high-risk asthma nurse in our clinic. So she was always there for a resource too, and she was the one that helped create the binder for us.
And I have to mention our adult nurse, Tabitha, played a huge part in onboarding me to the adult team. She was kind of over all of the adult stuff prior to my position coming on board.
I just had a couple of comments. Molly, you had mentioned that you're part-time, and so my question to you is, how do you deal with the challenges since you're part-time? You're essentially co-sharing a role. Mm-hmm. How do you come into those obstacles when you're not there every day, and is there any type of a kind of a handoff essentially of, who you took care of and what's outstanding?
Yes, I love this question because it actually was a huge challenge in the beginning because I was getting to know, I actually knew this person from I worked with her prior, so I knew her personally, but working with her just on Wednesdays in clinic was not a good flow for us. And so I work Mondays, Tuesdays, and Wednesdays, and she works Wednesdays, Thursdays, and Fridays. And we knew that was kind of a conflict because we were never able to pre-clinic or post-clinic about our patients, especially with culture results and everything. It was not good communication because in the middle of clinic, I would be like, oh yeah, this person grew, Pseudomonas, and she was like, okay, good to know. And so we actually created ways, we have a whiteboard in our room that we write down like important things that has happened if she wasn't there or if I wasn't there. And then she also switched to Mondays. And so she is no longer working Fridays because Fridays aren't really busy in our clinic. And so she's working Mondays with us because we sometimes see patients with our nurse practitioner. And so that way we can pre-clinic and post-clinic, and then Wednesdays we have clinic.
And then one thing I also thought was great that you guys were able to shadow beforehand, because I know that in my clinic we've done that as well, because I'm also a lung transplant coordinator, and I think that the ongoings of people when they're hired, you don't know what you're getting into, and then and I think that that's more welcoming too, so you can kind of answer questions. So I think that's great. And then one other thing is you guys kind of mentioned, the CF Foundation has various programs and LLCs, and one of them, you essentially mentioned, Jennifer, that you're taking the bull by the horns and putting together essentially what the foundation calls a playbook. So for each individual silo, so respiratory therapist, nurse, et cetera, that you're building that, if and whenever you do leave, I commend you for doing that, because it's important, and you're looking at the success of your program and for onboarding future folks. So that's great.
We do have a question on our iPad. Can you delineate the responsibilities of the coordinator versus the RN? Our clinic has a combination nurse coordinator.
Well, I kind of do a little bit of everything, but we do have the 2 part-time peds nurses who share their role. They're in clinic on the clinic days, and we have a part-time adult nurse who also goes to the adult clinics on her clinic days. So the majority of my stuff I do, answer calls and messages every day, faxes coming in every day. Between the 3 part-time people, I'm the only full-time person, so when they're not there, I'm covering. I try to get up to clinics at least every other week now. That's been a whole process trying to get me up there, as I was trying to learn my role more than being in clinics for a long time. But we kind of share a lot of the responsibilities, but I do attend the meetings, more meetings than they do. Working on the standard work instructions, the councils and committees that I'm involved with. But the day-to-day in-clinic patient contact is mostly on the nurses. Does that answer the question?
And I think that's important with meeting with your director or, your lead physician one-on-one on a regular basis, because then you can kind of sort those out. I'm not sure if that was your experience, Jennifer or Molly, when you guys have your regular meetings, but I think those are important, and I encourage everybody, if you don't already have that, not necessarily once a week if you're a fairly large clinic with everybody having multiple responsibilities, but at least maybe monthly. Especially as the newer staff members start out, I think that's essential, just to have those open lines of communication, definitely. So,
I think one of the things at our center that we try to, kind of what Sarah touched on, we have 3 full-time program coordinators. We're all nurses as well. And so we all kind of share the responsibilities and know the responsibilities of being the program coordinator and what that involves, but we all also act equally as nurses, and we take the calls, we split the patients. We try to get to know all the patients. We have a lot, but we all kind of have our set of own patients, but we cover for each other. Sarah, unfortunately, has more responsibility because she's the clinic manager as well as the program coordinator, so she has more things to do in regards to staffing and whatnot, but we try not to delineate too much as the 3 program coordinators, as and I think that creates better job satisfaction, honestly, because then we never wanted the newer nurse coordinator to feel like she was doing everything that we didn't want to do. Which is probably a lot, but or for her to think that we were giving her all the patients we didn't want to take care of anymore.
One other question that came in is, what is your nurse role in the clinic? Is your focus more in clinic or in the back house work? And I'm not sure if that was the both of you, but you both can answer it. Feel free.
I would say so on Wednesdays we're in clinic all day, and then we're answering sick calls, and we're kind of more responsible for the sick calls just because we kind of know our patients a little bit more, and we know when we saw them last and when we're seeing them next. And then also we pre-clinic for, I don't know if a lot of places do this, but we pre-clinic for our patients with our providers. So 2 weeks prior to the appointment, we discuss and go over our plan for clinic and what is our goal for this patient. And so I think that's very important. And if you guys don't do that, I really encourage, because it just kind of clarifies what our goal is for that day, and then it ensures that everybody's on the same page.
Melissa, I don't know, do you want to talk about how, it might be good for you to tell us, and then I can tell also how you delineate the responsibilities, you know, in the clinic as well?
So I manage the clinic by myself. I'm the sole nurse coordinator, and I have non-CF bronchiectasis. So essentially what I do is we've just hired LPNs. So if the LPNs can do a throat culture, fantastic. That allows me to go into the next room. So I think it's really determining what role and my team members can help me out with, whether it's social work and whatnot. I think that, you know, communication, again, is key, and whatever task, whether it be a disability letter or a school letter or a note, then I defer to my social worker. I'm email heavy, and I've trained my patients to either, you know, email or send my chart messages. So I think that's key, because then you can forward that. And it's, you know, I think with our population too, they're fairly young. So I think that most people don't want to talk on the phone. So I think that's just, you know, being open and honest and just telling patients, hey, I'm copying so-and-so, our social worker, onto this, or the respiratory therapist. I think that, you know, taking on a lot is just not sustainable. And I think COVID has, at least personally, made me realize what my thresholds are. And you just want to make sure you tap into your team as best as you can and as much as you can. So.
At our center, all the 3 nurse coordinator, program coordinators all act as primary care nurses in the clinic as well. And just to touch on what Molly said, we also have a weekly pre-clinic meeting with our 35 team members on Zoom, which is actually probably better. When we used to meet in person, it got very chaotic. But so now we meet on Zoom once a week, and we have 4 half day, or it's actually probably like 3/4 of a day. It ends up being clinics. And as the nurse, as a program coordinator and the nurse, we split the patients up evenly. We each take a primary assignment, and that way the physician can report to us, and also other members of the team can report to us if they need things done. It's like being the chaos coordinator, right, of clinic, because it's so chaotic. And so we act, you know, and we see the patients, we do port flushes and whatnot during clinic, as well as our other responsibilities during clinic. We just all kind of bounce around. Sarah, do you have anything to add to that? Yeah.
We do have a couple of medical assistants that help with, they can do flu shots and vital signs and checking blood pressures and kind of manning our emergency phone line and things, which has been very helpful to kind of be nurse extenders for us, which has been a great help.
Any other questions? All right. Thank you, Molly and Jennifer. Appreciate it.
Thank you.
Okay, next up, we're going to have my fellow co-moderator, Kathy. She's going to give us some updates and overall general discussion.
Hello. For those of you guys who were at the program coordinators luncheon yesterday, I'm sorry if you have to hear this again. I added some new things, so maybe it won't be as boring for you guys, but I really just wanted to talk. I don't have a ton of updates. This is just my first, let me just go through my disclosures, which there are none, and then. My idea was just basically to let you guys know, if you didn't know already, or as a refresher, what the CF Center Committee is and what the program coordinator's role on the center committee is. So if you are newer to CF or didn't know, the CF Center Committee is composed of about 12 adult physician center directors, 12 pediatric center directors, and they are responsible for doing your site visits if you've had one or have one upcoming, and talking about accreditation and whether your center is accredited through the CF Foundation. And so what this means is this group, in addition to one program coordinator, which is now me, and some key members from the CF Foundation, we meet twice a year in August and December, and we discuss accreditation status, the site visits that have occurred, and kind of up and coming new topics if we have time. The reason why I don't have much to report is because site visits were stopped during COVID, and so they just restarted them, and they did a bunch fast and furious. So my first meeting, I just took over this year from Jill Flagey. My first meeting was talking about like 20 centers and their accreditation, and is a lot to talk about. So in the future, I expect to have more reports because we're going to talk about more things than just accreditation. But, my role as the program coordinator is to be the voice of all program coordinators. So if any of you are program coordinators, you heard this yesterday. But the program coordinator actually didn't join the CF Center committee until about 4 years ago when Jill started. And a lot of things have come from that, the CF program coordinators toolkit, the monthly program coordinators meeting that's on Zoom, and changing the name program coordinator from nurse coordinator, who, for those of us who are here forever, we are always nurse coordinators. But if you didn't know, there are many coordinators now at centers who are not nurses. There's a pharmacist, actually, which was very cool. There's respiratory therapists, there's social workers, so there and other managers. So the role has changed quite a bit. So some of the new exciting things that are happening in CF centers and in light of modulator therapy, I just kind of wanted to let you guys know that from these meetings, there's a lot of talk about this. And I know people have asked a lot of questions about this, is how are things going to change in the clinic? How are these things going to change for the patients? Can we sustain 4 patient visits a year? I've heard from some centers that they are calling patients, weekly to get them into clinic because they really need the clinic numbers. We've heard patients who don't come in for years and years, if possible. And so these things are all changing. The landscape looks different. Staffing's changing. If you guys know what the CF guidelines are for staffing for nurses or social workers, this may not hold true in the future with modulator therapy because patients are needing to come to clinic less. They're not needing to do as many therapies, or they aren't doing as many therapies. So I just wanted to mention that there's probably going to be some opportunities for everyone, so you should keep your eyes open for that. This foundation is talking a lot about the task force of the future and how that works, how that looks different for pediatric patients who are starting on Trikafta early, versus adult patients. So this is all up and coming. These are all things that the foundation and the CF Center Committee has talked about. And I think one of the things is they wanted to hear data from things like the Simplify study and those kinds of things. So these recommendations can be based on data and science rather than just people guessing. And then last but not least, I wanted to mention, because as I did a poll of program coordinators before I started, I get a lot of questions about having site visits. And like I said, site visits were stopped for a few years because of COVID. They recently restarted. And so now I hear about a lot of panic, and people just, as soon as they hear they are going to have a site visit, it's just complete panic and pandemonium, and nobody knows what to do or people's responsibilities. And so what I wanted to mention, and our director had always told us this, is that do not panic, and just remember that these site visits are actually not meant to be punishment or punitive, or they don't want to, they're not the accreditation police. They don't want to see you fail. In fact, they want to see you succeed. And so you should look at your site visitor or site visitors as somebody who can actually help leverage things for you. And if you can be open and honest, they've seen it all before. They all run their own centers, and I can guarantee you nobody's is perfect. So they all know that there's deficiencies everywhere, and that you should really use them to help leverage with hospital administration. So if you need things, it's really helpful to open that up to them right away, because they can help you think of ways that they can help you with the hospital administration. And then the other thing to mention is, for those of you who don't know or don't get on it very much, because that's me, is my.cff.org is an amazing resource. And I know in our day-to-day lives, it's not very easy to get on it, but it's just actually, it is a wealth of information. Specifically for site visits, there's sample checklists, there's sample agendas, and it's just really helpful. it's a helpful resource overall, but specifically when it comes to site visits. And I just wanted to mention that because I get a lot of, in my new role, I got a lot of comments about what do they do, what are we going to do? We're going to be shut down, and it's going to be okay. So those are basically my updates. We have a gift of getting you guys out a little early. We had one more speaker, but she was pregnant with twins and could not travel, so good for her, sad for us. Do you guys have any questions about the center committee?
I had one question. In the room, are there any non-nurse roles like respiratory therapists, social workers, and whatnot? So, okay. What are your roles on the team?
I'm a social worker, mental health coordinator.
Okay, great. Fabulous. Okay. I just was curious because I know we keep saying nursing, so I want to, respect your individual roles because you guys are just as essential members of the team. And
I'm a doctor, and there's been a huge turnover, and that's why I was very interested, because we can't hire RNs anymore in the clinic. Only LPNs.
In terms of your the lack of nurses or whatnot, have you guys ever sought out inpatient nurses? Not that we're trying to take away from the inpatient, but maybe those that have been there at least a year or so, like, as we heard earlier, who, those nurses that have come from the floor clinic is crazy because I know when I first started out in the clinic, it's my manager told me in my interview, she says, well, whatever you don't take care of that day will be waiting for you the next day. Night shift or day shift isn't going to take care of it. So I think that was the biggest hurdle, I think, personally. But I think that, seeking out, as the two physicians in the room, have you guys ever approached or try to reach out to the inpatient folks?
Our administration feels that any RN that's hired has to be hired for the floor. So no RNs can be hired to any clinics.
Wow.
That's something important if you have not had a site visit or you have a site visit coming up to talk to. You usually know about a year to 18 months before, so if you haven't been notified, you probably don't have one coming up like next week. But that is really something good to bring up to your site visitor, because things like that where, and I've heard, where hospitals, treat every nurse as a nurse as a nurse as a nurse, and they don't vision this coordinator responsibility and how that can help the clinic overall. I think it's really hard unless you've had that for many, many years. And they can actually help or try to help with administration to explain to them, the understanding of why, nurse in a role like this, can help all the things that they want to hear, right? Decrease costs, it can help your organization, it helps the patients, it helps patient satisfaction. It's a little harder. There's a delineation, I think we've talked about this before, is when nurses are through the Department of Nursing, or if they're hired like under a different umbrella, like by the pulmonary division as like the coordinator. And I feel like it's a little harder from the nursing side, because especially now with the overall nursing shortage and nurses popping in and out and travelers, not enough staff, that it's hard to sometimes justify, why you would need to pay somebody more to do this kind of job and why it's needed.
Well, and I think to pick.
Grants for hiring different. One of our nurse coordinators is stay out of the grant.
Yeah, that's the other, yeah.
And we are not
Well, and one thing I think too that you can get salary support is through the CF registry funds. So I know that our database entry is the lady that enters the data to alleviate that off of my shoulders. Is our nurse, one of our managers, so our clinic managers, I'm sorry. She just really likes, all the data and just being involved and whatnot. So I think that's one thing that we use salary support to pay her for the kind of hourly entry. But then also I think that in terms of one thing that to get my position approved of, because I was the pre-lung transplant coordinator, also doing the cystic fibrosis coordinator role, and as soon as we received accreditation, I sat down with my manager. I said, we order X, Y, and Z, X-rays, CT scans, right upper quadrant ultrasounds, and we broke all the tests down. And you just will multiply it by how many patients you have. Sputum cultures, lab collections, and that also kind of helped to justify the amount of money that you're bringing in to the hospital. So I'm not sure if I'm preaching to the choir, if you've already tried to been there, done that, and you're like, yeah, nobody cares. And they're shaking their heads, but they're like, yeah, we're not giving you any more support.
I know.
So
I think hospital administration is tricky, especially right now, I think. And I don't know if either of the physicians here have other programs within their hospital. We've done this before, and we've also helped people do this. If you have another program like lung transplant, who has kind of, the model that you're looking at, lung transplant, ILD has one, liver transplant is to kind of talk to some of their people to see how they were able to get their staff the way they have it. Because typically those patients have coordinators, and I think that a lot of times, and nurses, their own specialized nurses. And I think a lot of times hospital administration, just because CF is so small, doesn't understand the multidisciplinary team, and everything that is involved with it is just as involved as liver and lung and heart transplant, and how that there's a significant need for that. So in the past, we've served as a model for other clinics who wanted to get team kind of like ours, our ILD clinic, ALS clinic, because, overall it really has helped patient satisfaction, and it helps all the things that they want to hear. They just don't see.
And what I think having, if you guys, if anybody has the patient family advisory boards, I think utilizing those patient comments and whatnot, just for what it's worth, to, have a survey sent out to your patients, and whatever they answer, or these, leaders. I know that we've had our patient family advisory board members offer to meet with administration as well, just in terms of a kind of a co-presentation. So again, I know it's, a lot of us are facing challenging times with administration, but when you have a patient right in front of you, I think sometimes it's harder to say no right up front. It might be in an email later on to the directors and whatnot, but I think that getting patients behind you, because as Kathy had mentioned before, whether you're there, 1 year or 25 years, I think that patients get attached and naturally want to have some continuity of care, definitely. So.
What happened to the nurse navigator role? Does the CF Foundation ever look at the nurse? That there's in cancer treatment and other chronic diseases that affect people, and for this long term and need this chronic management, they've had, there's this role of the nurse navigator. I feel like I haven't heard about it since COVID. It disappeared or something, but they were at the place where I used to work, Greater Hospital. They had nurse navigators that were kind of different than just your regular clinical nurse, because they did so much of that long-term care, and you want to have a relationship. And so I don't know if those institutions have nurse navigators at all, or if they, it's just another type. It's similar. I feel like it's a program coordinator.
I haven't heard much of it in the CF world.
I know that at my hospital, per se, we have nurse navigators, but they're more, they're a little bit different roles, and it's more of an inpatient type setting to help them folks transition from the inpatient setting outpatient. So I think a lot of the roles are all pretty much the same at the end of the day, coordinator, navigator, and whatnot. But I think that also, too, one of the frustrations that we had at our program was getting a designated CF respiratory therapist. We all know the importance of that role. And even with my program director and I, this is 4 years ago, we were coming back from a CFQI meeting, and we literally wrote the role as a RT navigator. And to get administration to buy in is just quite challenging. And I think that in this day and age, people feel more fulfilled within a job if you're praised by what you do, but also if you have specific job roles that you're serving patients. And I think that we actually lost our CF respiratory therapist, and we tried for 3 years to get the navigator role before COVID. And now she's working in the industry, still within CF, but it's just unfortunate because we continue to lose some great folks to other areas just because of administration. So I wish that they were in this room when they were listening to all of our feedback that we were given. But I do agree it's kind of dropped off that word navigator. Also, I haven't really heard it very much either. So.
In our clinic, it's 5 of us, respiratory therapists, that at some point were at the conference, went through the class, and we work inpatients and outpatients, and how inpatients could be. I myself love to go to the clinic every day, a week, to get away from the hectic, all the hectic environment. And same with the nurses. Our new nurse coordinator, she used to be an ICU nurse, and after COVID, she had it. So she's now inpatient, and I'm same with physical therapists. We have 5 people who were educated, and now we've just paid turns. That's how this works.
Yeah, I think you have to get really creative these days, and I don't know if Sarah could probably speak more of this as the manager, but I think between Sarah as the manager and our director, Jerry Nick, have had to be very creative in going to the hospital administration about why certain positions or certain things, that they don't think about can help benefit the hospital overall, like the 403B program. And it used to be that our hospital admissions, nobody recognized those as much, in that the hospital like that, of course, because they are getting money from that. But as those goes down, that's not as, but we used to use those kinds of things to leverage why we would need more positions or dedicated staff to the CF Center.
And one thing that we have a colleague that's getting ready to go out on maternity leave from our advanced lung disease side. So what they've done is they've taken 2 inpatient nurses, and it's a job share role. So they'll basically split their time between inpatient and in our clinics. So they'll still, help the floor out, not leave them high and dry, but also help to take them out of that hustle and bustle, grueling 12, 13-hour shift role, and allow them to kind of see the other side of things once patients are discharged and they go back to clinic for the routine visits. So we haven't really started that out, but I think that that's something that, basically the inpatient side is not being completely affected by on one end, because you still have nurses that are fulfilling their obligations of what they're truly hired for. But I think allowing us to, to receive help as well. I think that's kind of one idea that our clinic has tried out, but I don't have anything to report on how well it's worked. So just throwing that out there too.
I'm not a proponent of stealing staff from your hospital either, but I will say, and for those of you who are nurses in here, I was a clinic nurse, or I was an inpatient nurse. Sarah was an inpatient. Sarah took me from the inpatient side. They took her from the inpatient side. We took our Val from the inpatient side. Our new coordinator is also from the inpatient side. I think that there's a lot of, what's that? The old coordinators were too, and I think that, to get a nurse to be in this job, there's a lot of benefits to it as opposed to floor nursing. Especially now, floor nursing is a hard job. Okay.
It's nice to get to know the patients as a floor nurse.
Mm-hmm.
You get to know
Yeah.
and that's one of the things you're
Yeah.
excited
I think it piques your interest as a floor nurse that you know floor nurses who like the CF patients, you know floor nurses who don't want anything to do with CF patients, and those are not the ones you want to poach, obviously, but there are some that just, they just love taking care of the CF patients and they want to be more involved, and that's when we just grab them. RTs too. We've gotten our RTs that way as well, so.
Any other questions or remarks? All right. Well, thank you everyone for attending. We appreciate it. Have a good rest of the conference.